And I think that
Okay.
what prompted the interest more, and what I think is very useful of what you're doing, is precisely this notion of trying to understand the numbers better. Because right now we are all confused, and there's a kind of a lot of numbers everywhere. And as I was joking with someone, suddenly everybody just got to be an expert, or just converted into an expert in virology and statistics, and it's suddenly everybody can now interpret statistics and virus and all that. But we know that that is not true. I mean, you are the scientists, and you are the ones who are, understanding these better. So we understand you have a new release, and you just put a new paper. Would you like to explain us a little bit of the context of that, and what is the main message?
Yes, we were looking in our paper today at case rates, that is the number of cases, and we're looking at it by the major race ethnic groups in California: white, Latino, Black, Asian, American Indian, and Pacific Islander. And we looked at it in young kids, young adults, early middle age, late middle age, elderly, and old elderly. And over the course of a person's lifespan, basically, Asians had about a 50% higher case rate than white. African Americans had about twice, about 100% higher, twice the rate. Latinos had 3 times the case rate of whites, 3 times, from kids through old elderly. And if you want, I can pull up some of those data and share them.
Now, why is this, doctor? Why do you think is that happening?
Well, that's a very good question. Or I can get into that. Are we with everybody? Is everybody listening now, or
Yes,
not yet?
yes. Everybody is listening. We have 49 participants now.
Okay, very good. So let me explain what this means.
Okay.
In order to have COVID, the COVID disease, you had to have been exposed to the coronavirus. So that in many ways, as we understand the patterns of cases of COVID, we can start to get a sense of who's being exposed. And because Latinos have 3 times the case rate of whites, African Americans have twice, and Asians have about 50% more, it appears that Latinos are more exposed. And in fact, as we have detailed in some of our earlier reports, it is because, although people didn't realize at first, Latinos tend to be the essential workers. Now, the way to flatten the curve, remember that phrase 10 weeks ago? We'd never heard of it. We wanted to break the transmission. Coronavirus is a communicable disease. I breathe on you, I can give it to you. Not like a heart attack. You know, I can breathe at you, I can hit you. I'm not going to give you a heart attack. I breathe on you, I can give you. It's a communicable disease between one person and another. So if people stop breathing on each other, then the chance of actually acquiring the coronavirus and actually developing COVID goes down. So we were told immediately, stay at home, stay with your family. We're closing the schools. Your kids will stay with you. Don't go out. Don't talk to anyone. Don't open the door. Wonderful. A lot of people were able to do that. People that had nice jobs, they got a regular paycheck. They don't have to worry where it's coming from next month. They could work telecommute. They usually are the type of people who also have really good health insurance. They have access to a doctor, so they could hunker in place. But what people didn't realize is in order for some families to stay at home, other people had to work in essential businesses so that they could stay home. Let's talk, for example, about eating, food. Where do you get your food? Food is grown by farm workers out in the countryside who even now work without personal protective equipment. They're working in squads, in cuadrillas. They're totally exposed, and they're exposing one another to coronavirus. After they harvest, things go into the packing sheds. For example, avocados, with aguacates, we have una empacadora here in Southern California. Out of 80 employees, they do aguacates. About 45 tested positive for corona because they're tight together. In the meat processing plants, the workers are shoulder to shoulder with no personal protective equipment. They infect each other. Then you have truck drivers who are largely Latino, bring all the products into the city. They go to the grocery stores, the shelf stockers who put the products on the shelf, the checkout clerks as people leave. If you stop and consider, up until recently, they were not offered personal protective equipment, and your average checkout clerk passes within this close to about 200 or 300 people every shift without personal protective. Mm-hmm. The construction workers, the auto mechanics, the gardeners, if you will, the assistants, the attendants in nursing homes, these are primarily jobs, these are occupation industries disproportionately occupied, filled by Latinos. However, Latinos are still, even after Obamacare, twice as likely as everyone else not to have health insurance. There's a tremendous doctor shortage, so that Latinos are 6 times more likely not to be able to find a doctor, particularly one that speaks Spanish. So here you have population that, because they are essential workers, are being exposed to coronavirus, are less likely to have insurance, less likely to have a physician. And in the very first week, the California State Department of Public Health said in Spanish, if you have symptoms, if you have a fever, if you have a cough, hable con su doctor pronto. What doctor? If I can't find one, I don't know how I'm going to pay. So Latinos have been essential workers, but we didn't think of them as essential workers that needed personal protective equipment. We thought doctors, yes, they need it. Nurses, yes, they need it. It never occurred to us that farm workers might need personal protective equipment. Now, early in the first few weeks of staying at home, if you remember, in grocery stores across the country, people were fighting over bags of toilet paper and paper towels. Remember that? They were in short supply. They were fighting. Just think if they were fighting over food. That would be very serious. So here you have farm workers, almost 100% Latinos, almost 100% immigrants, probably 60, 70, 80% undocumented. Very essential. Without their work, we could not eat. We couldn't stay at home. But in spite of being essential workers, not only do we not offer them the personal protective equipment, not only do we not offer them health insurance or access to a doctor, we can deport them at any moment because they're undocumented. We can deport them. So we have been the essential workers, Latinos, and yet people don't see us as that. It's just the doctors and the nurses.
Okay.
So that is part of the reason why we're now seeing the curves that we see. Latinos are have three times the case rate of non-Hispanic white, because non-Hispanic whites have been able to shelter at home. Latinos have had to support them so that they can shelter at home.
So we are understanding this well. The main reason of this disproportionate affection to the Hispanic community from the COVID is because of socio-economical conditions, not genetics, not that our race is more propense to get the virus, not nothing. It was mentioned at the beginning that in New York, some patients were African Americans, and most of the patients were like overweight or diabetic or things like that. Does this also has something to do, or is just mere false conclusions or data?
It has very little to do in terms of being exposed to the coronavirus. From the studies in China and Italy and Spain, and those were the only sources we had to learn about what happens when the coronavirus actually sweeps through an area. Once somebody had COVID, once had actually developed the disease, then if they had comorbidities, for example, yes, obesity is a comorbidity, having diabetes, having a heart condition, having renal disease, having an immunocompromised system, all of these are comorbidities. So if you had a comorbidity and you developed COVID, then your chances of mortality were higher than if someone who had only the COVID and no comorbidity. But that's way at the end. What we're seeing is exposure. The coronavirus does not discriminate. It will fall upon everyone, whether you're skinny, obese, whether you have diabetes, whether you're not, whether you exercise, whether you don't. It doesn't matter. The coronavirus does not discriminate. However, some people have, if you will, a protective social umbrella. They have a job that they can telecommute to. They have health insurance. they have access to a doctor. So that the coronavirus is raining down, they have a protection of an umbrella. What umbrella does a farm worker have? What umbrella does a bus driver have? What umbrella does a grocery store checkout clerk have? Almost none. So they get exposed. So they're more likely to develop. It has nothing to do with whether they have diabetes or not, whether they're overweight or underweight. It has nothing to do with this, the exposure. So that becomes possibly a factor way at the end. But it's not what's driving the exposure. It's the exposure that we're seeing. That's why we're looking at the case rate, not the mortality. What's the number of cases per 100,000 that we get? And in California, Latinos have 3 times the case rate as non-Hispanic white.
Now, doctor, how does it compares the rate of infections to the rate of mortality and the rate of recovery in the Hispanic community? Is there any differences? Are Latinos recovering faster or slower, or the morbidity rates are higher than other communities?
We have only a very partial picture because remember, this coronavirus is new, and what we thought we knew about it, we learned from what happened in China 2 months ago, what happened in Italy and Spain a month ago, and it has a life. Let's just start with one scary thing. If you have, for example, your child, you get measles, you get it, it's a little bit uncomfortable for a week or two, and that's it. And you'll never get it again. You've developed an immunity to measles. Yeah. Or if you get chicken pox, you develop an immunity. So some thought was, well, maybe if you get COVID and you recover, you won't get COVID again. But now we're seeing cases of people that have recovered and suddenly they're testing positive again for COVID. So maybe it doesn't confer an immunity, or maybe only sometimes, or if it does, for how long. So it's not like measles. We think, okay, you get it. You've heard this herd immunity business. Let everybody get it. A few will die, but most will develop. We don't know that's going to happen with us. In fact, we're beginning to suspect it might not. Also, now we're beginning to see people that have had COVID have recovered, and they're having lots of sequelae, things that follow on. It seems to cause then other condition. It makes heart situations worse. It makes lungs situation worse. If you have renal situation, it makes it worse. So it seems to make things worse that you got. There seems to be some sepsis that's involved that wasn't there before. In children, it seems to have some effects we weren't thinking here, because children didn't seem to die so much from it. They would get it. So we're just beginning to learn in this population here, if you had COVID and you recover, that might not be the end of the story. There could be other things going on, and it appears some people are getting it twice. But this is all very, very partial, very, very early data. And one of the problems is that as of last week, only 3 states collected data specifically identifying Latinos: New York, California, and Utah. So we don't know what's happening in Texas because they don't break out data yet on Hispanics. We don't know what's happening in Michigan. Eventually, those data will become available. Right now, only 3 states are reporting it. So we have very, very spotty, sketchy data. We're learning that we may be a little bit different from China. We may be a little different from Italy and Spain, or maybe they didn't report everything. Maybe they didn't follow it enough. So we're just learning about this.
I guess it would be the same with blood type. It also was mentioned at some point that might be that the Latino communities and the Latino nation in Latin America that usually have a prevalence of the O type of blood might be more resistant to the virus, but I guess that is not proved either, right?
Let's put it like this. There are a lot of hypotheses running around. And in fact, we are partnering with the local government here to do a seroprevalence study just to find out some of these things. But hypotheses without the subsequent investigation are just that, they're just hypotheses. I remember, in about the 3rd week of the COVID crisis, I was on a conference call with people around the state, and somebody noticed that in the Samoan Islands, there at that point had been 0 cases of COVID. So somebody said, well, maybe because it's warm and there's ultraviolet. Do you think that's the case? And luckily, the day before, I had been on a conference call that included people from Lima, Peru, Manaus, Brazil, and Guayaquil, Ecuador. And I said, well, I don't know about the Samoan Islands, but in Guayaquil, they're right on the equator. There are bodies lying in the street. They can't even pick them up. They're just making estragos in Lima. And those are warm places with the same amount of ultraviolet. So I'm not so sure that you can say just because it's warm or they have ultraviolet light, they're going to avoid any effects, because I'm seeing other cases. So yes, you hear a lot of things. I like to, first of all, let's try some common sense. Does the heat make it go away? Well, how about Ecuador? Did make it go away? What about Manaus? It's in the Amazon. Very hot, very moist, didn't go away. So it might be more complicated than that.
Now, Doctor, you are at the epicenter because, I mean, your center for studies on the Latino health and culture in UCLA has been doing a lot of research. You've been publishing books about the health of Latinos, like La Nueva California years ago, that made history. Mm-hmm. And we are now seeing, and I said you are in the epicenter because you're in California, one of the most active states, and you know, where we have like different points of view. And what we are perceiving, and correct me if I'm wrong, is that the situation has been polarized, in which on one end we have the politicians and the economical forces trying to open and trying to save the economy and trying to make people go and start their lives again, so the economy and things like that doesn't suffer more. And on the other side, we are seeing scientists and health officials, you know, preventing and warning that they might be opening too soon and pushing too far for the reopening, and this might trigger, you know, a new spikes on this. So how do we balance those two points of view with a logical and with a balanced decision?
Well, you know, this is a problem that's very common in medicine. And when it's just one-to-one, it's called the non-compliant patient. So you have a patient, maybe has a heart situation, and you suggest maybe this should change their diet, reduce the salt, reduce this, reduce that, try eating a little bit more green stuff, and the patient nods and goes right back to eating the same diet. Yeah. Well, you think non-compliant, you're doing yourself harm. Well, the patient just said this yesterday that I'm aware of. You know, I don't want to live the rest of my life eating food I don't like. I'd rather eat in food I enjoy, and if I die, I die. Okay, that's the patient's decision. Coronavirus is a little bit different because it's not just one individual. You can breathe on someone else and they can die. It's different from changing your diet. So here we have a group of non-compliant patients who not only put themselves at risk, but are demanding the right to put other people at risk. Now that's where things become a little bit more complicated. Does someone have the right to infect me? Do I have the right to infect somebody else? This is different from changing my diet because I have a heart condition. Society is involved in this. So I think what we need to do is develop our metrics so that we know when we open things step by step. I mean, clearly we can't shut down an economy for a year or two or three. Month or two or three is long enough. And because who actually is feeling the effects? Primarily Latinos are feeling the effects, because Latinos work for these small businesses or run small businesses that were immediately shut down without, of course, the insurance or the access and everything. So Latino businesses have suffered, and we are doing some work on this with our colleagues in the Latino GDP. Hopefully in the next couple of weeks, we'll be able to give some good data, but it looks, at least preliminary look, is that Latinos have about close to 20% higher unemployment rate than everybody else. We're more susceptible. We work with the smaller businesses. We tend not to work in government. So we have been more affected. So we get more affected by the business closure. We get more affected by people that want to breathe without facial coverings. So we're being affected up one side and down the other, and yet Latinos are the essential workers that are moving the economy ahead. There is one big difference between, I guess, the heart attack example and the face mask example is different societies do things differently. For example, here in the United States, the idea is, well, I'm wearing a face mask to protect me from you. In other societies, say in Japan, people that wear a face mask say, I'm wearing a face mask because I'm thinking of you and I don't want to breathe on you. I think of you. So I'm doing something not to harm you, as opposed to here, it's I'm doing something because you might harm me. There's a big difference then in the social effects. If another example we might want to think of, everybody here looks pretty young. I remember when I was an undergraduate at Berkeley, half the room used to smoke in a lecture. This is in the 60s. I was just normal. Everybody did it. Nowadays, it would be unthinkable. I mean, you just literally wouldn't think of doing that because the social norms have changed around that particular behavior, around smoking. So here we have a situation where face mask has been apparently made into a point of contention. Some saying, you're taking away my liberty to breathe. And other people saying, well, yeah, but do you have the freedom to exhale coronavirus on others? And yet other societies say, you know what, our society, our social network is really important. I need to protect my social network. I will wear a mask so I don't cause them harm. That's a very different approach. But we're doing that with smoking. We no longer smoke on airplanes. We don't smoke in classrooms because it's just right now, it's literally unthinkable. You just don't think about doing it. It's not what you would do. It's now a social norm. You don't need a law. It's a social norm.
So how can we, I mean, I was reading your study and I think it's really interesting on how can we try to understand the numbers better in the different states, the different regions, the different cities, maybe even the different, parts of cities to understand what should I do. Because right now, it seems also that even when the government and the CDC are issuing like guidelines for reopening and guidelines for starting to go back, then now it comes to also the community and the individuals to decide, okay, they are allowing me to go into a restaurant, but will I go to a restaurant? Do I feel comfortable? Do I feel safe going out already, or should I wait? Is it the same safety that I will feel in a store in Los Angeles than a store in Texas or a store in New York? So how do you recommend us, that we are not scientists and we are sometimes very confused by the media, and not only the media but the social media too? I mean, if you see all the postings and the Facebook and Instagram, everybody's posting things, and who knows which of those are really true, and which of those are just news that are not even sustained. So what do we do? What is the best advice for us?
Well, usually for Latinos, whether it's COVID, whether it's diet, whatever it is, I often think, so what would Abuela have said? And Abuela would always say, you must take care of others, you must take care of yourself. Bien educado, you take care of others, you worry about them. And Abuelas usually had a lot of wisdom, trying to take care not only of yourself, take care of your family, take care of your friends, work with them, eat healthy, sleep well, try not to fight with each other, remain calm. Very, very good advice. So if you're going to make a decision, do I go to a restaurant? Do I take my family? Just kind of think of what would Abuela say. That's probably the best overall, just general advice. Would Abuela say, this looks pretty dangerous? Maybe I shouldn't do that. We do need to maintain, because we don't know so much about this corona. We don't know that you get an immunity once you've had it. So we would want to protect our family. We'd want to protect ourselves in our interaction with others. So if everybody is wearing a face mask in a store, probably that's a pretty good place to go into. Because remember, the real use of the face mask is so that you don't exhale things out towards others. You need you need an N95 to protect you from stuff coming in, but we can all help not exhale coronavirus simply by wearing a cloth face mask. It doesn't have to be a very fancy one with a high scrubby filter. So it's just making sure, what are my potential for exposing myself or my family to someone who might be positive. And if they too are taking measures, wearing face masks, maintaining social distance, that's probably not a bad place to go. But when you have people not wearing face masks, demanding not to wear face masks, behaving inappropriately, then that might not be a smart thing to do. And yes, it's hard to take decisions. Not only do we have different levels of government saying different things, contradicting one another, because of our form of government, you have state guidelines, you have county, you have city, you may have special district, and they may conflict with one another. Mm-hmm. Just like when you have a situation, you go to see one doctor and doctor says it's this, go to another doctor, well, it's kind of like that. What do you do? And I'm not a doctor, so how do I make a decision? How do you decide? Think of what Abuela would do.
Mm-hmm. Well, that's a very wise advice, which appeals to common sense, right? Common sense is the best remedy sometimes. And this brings me to another lecture that we've been doing on the media on how these pandemics end. And I was reading that some people say that there's two ways to end the pandemic. One is the medical way, in which the scientists find that the virus is no longer that deadly, or they have found a vaccine, or the virus simply mutates and or goes away, or something happens, right? And then the other part, it has nothing to do with science. It is just people getting bored of being in lockdown and restricted, and they just decide that, I'm going to start continuing with my life and doing my work and going out and little by little. And it seems that over the history of humanity, in many pandemics, we have had both endings of a pandemic. And what is your vision about this? What is the social? Because at the end of the day, that common sense that you are talking about, the abuelas in the Latino community, is the same common sense that people will start applying soon if things don't change in terms of a new vaccine or scientific discoveries, right?
Right. As Latinos, we have our origin in the epidemic of the conquest, the epidemiology of the conquest. When Cortés laid siege to Tenochtitlan, it didn't fall because of superior Spanish armor or because they had guns or horses. Cortés won in part because one of his soldiers infected the city, didn't mean to, with smallpox. And smallpox was a disease against which no indigenous society had any built-in resistance. And within the next 80 years, the population of Mexico, what's now Mexico, went from 25 million to 1 million.
Wow.
And we saw similar profiles all across the Americas. In some of the islands, like in Puerto Rico, Cuba, La Dominicana, the mortality was 99+%. There was a huge implosion, a population implosion, which then left a space for people to come from Africa, from Asia, from Europe, and create the mestizaje that's now today Latin America. If it weren't for the epidemiology of the conquest, we might all be speaking Mesoamerican languages today. But it did happen. We have our origin in these sorts of epidemics, and it resulted in us. What can I say? Let me give you another example. People here look so young. Anybody remember HIV? Crickets. It happened so long ago. What's that? Okay, HIV, when it first broke out, And I was at the School of Public Health in Berkeley at the time when it broke out in the Bay Area in the early 80s. If you were diagnosed as having HIV, it was a sentence of death. You were going to die, period. The only question is how quickly you're going to die. Then about 15 years later, they developed, it was called the drug cocktail that would keep you from dying. Now, your quality of life was not very good. It was very expensive. You couldn't miss a dose. At least you weren't going to die immediately. Today, we still do not have a vaccine against HIV. And we've been looking now for 30 years. Still no vaccine. And yet, we don't worry about HIV the way we did. We've learned how to live with HIV. We don't have the same trajectory that we used to. People have changed their practices. In theory, we're now doing safer sex, etc. So it's no longer top of mind the way it used to be. And we don't have a vaccine. We learned how to manage it in our daily life. So on the one hand, we don't necessarily need a vaccine to manage coronavirus, but we may need to learn how to live with it. On the other hand, we saw what happened, what led to the growth, the development of the mestizo population of Latin America was the smallpox brought by the Europeans, against which no Indian group had any immunity at all. So we have these two in our very backyards.
So if you I know that you sometimes consult with the authorities and you have your advisory practices as well. And I guess that your Department of Health in UCLA should be, or it is a relevant aspect. What is the main recommendation that you and your community of scientists are giving to the authorities and to the community in general? What we should do?
Well, the main thing we should do is, there are two things everyone can do. Well, not everyone, almost everyone can do. And if you can't do them, you can help somebody else do them. Register and vote. Because you talk about the health authorities, et cetera. Well, guess who they're responsible to? We, the people. But if we're not registered, if we're not voting, then we're not holding them responsible. And 1 million Latinos this year have turned 18 who were born here in the United States. They are United States citizens. Oh, by the way, last year, 1 million Latinos turned 18. And the year before, 1 million. And next year, another million. If we can just get them to register and vote, we can make our voice known. That's the most, and if for some reason you cannot register and vote, certainly help other people, support them so that they do register and vote. We need to raise our voice. That is how we change public policy in a democracy.
Mm-hmm. That's correct. Yeah, I know that's been a fight for over many years. Mm-hmm. So, Doctor, if you agree, I would like to open for some questions that we've been receiving. So, before going to wrap up or the final couple of questions from us, I just want to open to some of the questions, and Sarai now is going to take care of stating those questions to you. So, Sarai, please go ahead.
Great. Okay, thank you. So we did have a couple of questions coming in throughout the interview. The first question I'll go with Ana Matiela. She said, "Is this California data you are sharing or national data? Thank you for considering this question."
Mm-hmm. As I mentioned briefly, it's California data. We do not have national data because as of right now, only 3 states are reporting Hispanics in their data: New York, California, and Utah. I wish we had national level data. Right now, we don't. Someday we will, not right now. So yes, I'm limited to California data because I can access it. It's fresh. My data are only about 2 days old at the latest. But unfortunately, it's only California. Other states need to begin to report Hispanics so we can get a national profile, which is why, again, it's important to register and vote. If your state is not reporting out Latino health, they need to.
Great. Next question. Omar Nevares says, "Does density of the household also play a role in the transmission of COVID? In San Jose, California, we see multiple families living in the same household due to high cost of living."
Well, yes, it does, but let's put it in its context. Because I don't want this to be, oh yeah, those Mexicans, they just all crowd in. They just don't know how to live. Housing costs are sky high. So, and usually Latino wage earners, if they're employed, tend to have lower wages than others, and they're trying to rent. Classically, Latinos have tended to have more persons per household than non-Hispanic white. In fact, your average non-Hispanic white household consists of one person, solo, alone, one. That's normal, not for Latinos. So we tend to live, and of course, high cost of housing only makes us live even more. And we also tend to have more multi-generational families, the grandparents, the abuelos, the parents, and the kids. So living together, and the order is given, stay at home, shelter in place. So the children stay at home, the abuelos stay at home. But the parents have got to work because they're essential. They're creating the meat, they're checking out the groceries, they're growing the food, they're fixing the cars, they're driving the buses. And because they're low wage earners, Latino households classically have more wage earners per household than non-Hispanic white. So you have 2 or 3 or 4 adults leaving the house, keeping the society together, but becoming exposed to coronavirus, then coming back to the house. Now, if they didn't leave the house and work, how would people in Beverly Hills eat? But people in Beverly Hills don't think about how that eating is possible. So yes, then you're going to get more, and I think that's probably part of the explanation for why you're having a higher case rate amongst Latinos. But remember, it goes back, not because Latinos live more densely, because Latinos are the essential workers that have been working for 2 months without personal protection equipment, without health insurance, without access to medical care, without testing. That's why we're seeing ultimately the higher case rate.
Great. Next question is by Frank Gomez. He asked David, how do you explain the lengthy delay among so many in recognizing the greater risk outcomes affecting Latinos? The oblivious media, lack of studies besides yours?
Well, like I said, initially, in fact, we had no data about Latinos. So I think the state of California began breaking out Latinos just almost exactly 4 weeks ago. That was the first data we had. I believe it was April 20th was the first breakout. So we didn't know. We could only suspect by looking at earlier patterns with different diseases. And I looked at communicable diseases because that's the way this is transmitted, not a chronic disease. And it's worked out pretty much the way I thought it would, treating it as if it were a communicable disease, however, one that has death at the end. If we don't have data, and I'm a researcher, if we don't have data, it's hard for us to know what's happening. There are a lot of hypotheses, a lot of screwy hypotheses, ideas, this and that, the other. I'm a data guy. I like to look at data. So Latinos, the 60 million Latinos in the United States have managed to create the world's 8th largest economy. We should be investing in what Latinos are doing. Instead, people say, oh, Latinos are freeloaders. Why give them anything? They're just going to gamble it away or something. Let's look at the data. Did I answer that question enough? I tend to have a lot to say. I want to make sure I get to the core of the question.
It might be that he wanted to get a sense of why the authorities are or seem to be relegating or not prioritizing Latinos in their actions and recognizing the impact in this community as they recognize the impact in the white community. It might be that, I don't know.
Okay, well, if that is certainly the case, and that has a long, lengthy history, about 160-year history here in California. Again, it has to do with the mental model people have of Latinos. And the mental model that people have is that Latinos are a dysfunctional group. We have the wrong culture. We're criminal. We don't want to work. We'd rather live on welfare, blah, blah, blah. Oh, no, by the way, we have horrible health. We have a lot of heart disease. We have a lot of cancer. We have shorter life expectancies. Our babies are dying like flies. In my book that Jorge alluded to, in fact, I did an update in 2017 called La Nueva California. I take all these popular images that people have of Latinos, and I use data from 1940 to 2015, 75 years worth of data just to see, okay, really, were Latinos living on welfare all that time? No, in fact, Latinos use welfare the least. Were Latinos really lazy? No, Latinos had the highest rate of labor force participation for 3 generations. Were Latinos really sickly and coming across the border to fill up all the waiting rooms? No, Latinos are the healthiest population. So I believe in using data, and if you all want these data, you can get it. It's published by the University of California Press, La Nueva California, Latinos from Pioneers to Post-Millennials 2017 by the University of California Press. I hear one thing in the popular media in English, and it's not conservative or liberal media, it's the same image. I don't care what their political orientation is. They seem to have this idea that Latinos just somehow aren't really Americans. I look at the data and I see a completely different picture. And that's what I like to share, that picture. I hope I've been sharing some of that here. Yes, we're suffering from higher case rates. Yes, among the elderly, we have a higher mortality rate, but not because we're somehow weaker. It's because we are out there making this economy run, taking the risk every day.
All right.
Next question is from Alexis Velasquez. Is there any data on asymptomatic cases in Latino communities?
Well, let's put it, I wish there were, but remember, to get into the data system, you have to have access to a physician. You have to know how you're going to pay. You have to have insurance. And even still, even though now you, in theory, you could get tested, you have to have symptoms to get tested, at least in Los Angeles County. So if someone is asymptomatic and doesn't have easy access to a doctor, they're not like the LA Lakers who could order up tests the very first week. They don't have access to boutique physicians who are getting a $5,000 a month retainer so they can get their tests right immediately. How are they going to get into the system so that we know they're asymptomatic coronavirus positive? That's why we're doing the seroprevalence project, because we actually want to look at this, but that takes a while, quite a while, and quite a bit of effort to do. We have to actually draw bloods. That takes institutional review. Then we have to get the laboratory work done, then we have to analyze it. And when people just think that Latinos just aren't worth it anyway because we should all be deported, why invest in that? That only makes it more difficult. We are an integral part of this country. We've been an integral part of this society. In many battles of the American Revolution, there were more soldiers that spoke Spanish rather than English fighting for the independence of the United States. We have been part and parcel of this country. The oldest Western-based city in the United States was San Juan, Puerto Rico, 1521. So we've been part here since day one. Just some people don't want to believe it. But we were the past, we're the present, and we will be the future.
Next question is from Sebastián Ontiveros. Is there any positive news to share from your perspective? I believe the unaddressed symptom of this pandemic is the mental health of the Latino community. For all the reasons you've highlighted, given the essential worker status of the community, there will be a mental health ramification for those who survive the virus or do not contract.
I have no doubt there are going to be those stressors out there. And yet there's something interesting. And I'm not a mental health person, by the way. I'm not a psychiatrist, psychologist. I'm a researcher. And when we research heart disease, cancer, stroke, pretty much in the medical community, we agree upon certain things like what's a body temperature, what's a body mass index, etc. We can agree. And when we look at those data, wow, Latinos have 30% fewer heart attacks. All I know is when I look at the mental health literature, for example, are Latinos more depressed than, say, non-Hispanic whites? And literally, it depends upon the instrument that you use to diagnose is somebody depressed, and were these instruments developed on a non-Hispanic white population, then just translated to Spanish? There is not a clear answer in the research literature. Are Latinos more or less depressed? Clearly, if you look at the external conditions, very negative statements coming out of government, deportations, discrimination for 160 years, for Pete's sake, you should think we should be horribly depressed. Yet we also have some agency and strengths within our own community that's called the barrio advantage. Somehow living in a barrio, even if it's a poor barrio, confers an advantage. It reduces your risk for heart disease by 30%. So yes, there are huge stressors. And it would be really nice if we had more Latino psychiatrists and psychologists. It'd be great if we had more mental health services. But it doesn't mean that we've been incapacitated for the past 160 years. We do have strengths, this barrio advantage, as it's called now in the medical literature, that just think if we invested in that barrio advantage, man, we'd be better than Sweden or Japan, I think.
Michelle Del Toro asked, as advocates for Hispanic health, what do you recommend we do to continue advocating and push for the better collection and reporting of Hispanic Latin data?
Okay, what did I say? The two things we could almost all do: register, vote. Because that tells the state that you live in, yes, you should be collecting Hispanic data. And the state tells the county, yes, you should be collecting it. And if you don't have that pressure, they won't collect it. Why should they change their systems unless someone tells them we need this, and someone that they have to listen to? And elected officials have to listen to voters. That is why some elected officials don't want people to vote. They'll do the gerrymandering, they'll suppress the vote, because the vote is very precious and it's very powerful. In the end, more powerful than money. Money buys votes. Votes don't buy money. Votes, votes, votes. And if you cannot vote, you cannot register, encourage those who can to do so. Get on their case. Don't let them rest until they do it.
All right.
And another question from Alberto Juarez. Can you explain how border communities such as San Diego and Tijuana have a higher symptomatic patients, especially in the Latin community?
Okay, I can only answer half that question, and not the other half, because we simply don't have the data. The major focus, the source of infection for Western Mexico, for the state of Jalisco, was Vail, Colorado. Colorado, how does that affect Jalisco? Well, it turned out late February, early March, a group of about 25 people from Guadalajara vacationed in Vail. And Vail, by the way, is one of now the epicenters in Colorado. While they were skiing, maybe having dinner at night, they were exposed to other people that had the coronavirus. Then they went back to Jalisco and they took it with them. And now that was the beginning of the brote in Jalisco. HIV didn't begin in Mexico. It was taken from the US to Mexico. So even though there is this idea that somehow Mexicans bring disease to the US, actually in these communities, quite often it's the other way around. So yes, there's a situation in Tijuana. There's a situation in Mexico. And again, we can only make the conclusions based on the data that are available. And as here, I hear contradictory things about the coronavirus COVID situation in Mexico. Mexico City has, what, 22 million people, and there are only a few thousand cases. But then half of the population of Mexico doesn't have a formal job. They don't get a formal paycheck. They're not going to be in Seguro Social. So how do we understand even just the case rate, much less if they're symptomatic, asymptomatic, or whatever else? We need better data to be able to say anything about that.
Now, on that sense, Doctor, what we see in Latin America, I mean, other than Brazil and I think Peru, that are very high, we see most of the other countries, including Mexico, like even below states like Texas and other countries. Why is that? Because of the lack of enough testing? Is because there's so, I mean, I know you don't have the data, but your guess is what, if they were doing the same kind of testing that they are doing here in the US or in Europe, do you think the cases will be as dramatic as we have them here?
I don't know, but if we had wider testing, we would know yes or no. Is it underreporting, under testing? That's why the testing and the population-based testing is so important, just to understand what are we working with. If in fact you get COVID and you recover, can you get it again? Does it not, or does it confer immunity? We don't even know the answer to that. So the more data, the better. Then we can start to respond better to these questions.
Exactly. Well, thank you very much. I think we have gone through our time for 1 hour for this interview. I don't know if you have something else to add. I think that the study that you are publishing and you just updated this morning is very, very good. I would suggest, like most of the participants, maybe go to a certain website of your Center for Studies and maybe get the entire study, read it, read more. Remain reading serious articles and reliable sources as opposed to just news and social media postings. But do you have something else to add, Doctor?
Yes, I would make a suggestion. Two other things people could do. I have written 2 books, and I would strongly urge you to buy them and read them. One, I've already mentioned, La Nueva California, Latinos from Pioneers to Post-Millennials, published in 2017 by the University of California Press. I wrote a book 8 years ago called El Cinco de Mayo, An American Tradition, in which I explain why it is that we celebrate the Cinco de Mayo so much here in the United States when it's scarcely celebrated in Mexico, particularly outside of Puebla. And it has to do with that we were here during the American Civil War. The Cinco de Mayo was our experience of the American Civil War. It was our way of saying to the world, here is where Latinos stand on the issues of the Civil War. We oppose slavery, we support freedom. We oppose white supremacy, we support racial equality. We oppose elitist plantation rule, we support government of the people, by the people, and for the people. That is why we began celebrating Cinco de Mayo in the United States. We need to understand, we were part of the Civil War. We were on the right side. We helped fight the American Revolution, and we're helping to heal this country more and more every day. Those books give you all the data you need.
All right. Well, thank you very much, Dr. David Hayes Bautista. He is a distinguished professor of medicine and director of the Center for the Study of Latino Health and Culture for the University of California at Los Angeles. Really, thank you very much for your time. I think this is very, very, very useful for us to understand. We praise you for the work that you're doing and the good representation of Latino scientists that you do in the West Coast and all over the country. So thank you very much, and hope to talk to you soon again.
Okay, thank you. Goodbye now.
All right. Thank you very much.